St. Elizabeth. So if we could just go around and introduce ourselves on the phone, that would be great.
I'm Karen Fleming. I'm the clinical nurse educator for the pediatric unit at North York General.
I'm Kim Hogan. I'm a nurse practitioner at Sick Kids, and I do a satellite clinic for complex care at North York General.
Hi, it's Anna Cooper. I'm the clinical practice leader for pediatrics at Bayshore Healthcare.
And I'm Nathalie Major. I'm a pediatrician from CHIO with complex care, and I'm one of the co-chair as well. And I'm here with Erin Alcade, one of our nurse coordinator who's been with the program, as well as Karen Morris, who is a new team member to our program. She's an NP in complex care.
Great, and it's me, Lisa. I don't know, is there anybody else online that we've missed?
Hey, it doesn't sound like it, so we'll see if others join. But okay, so today we are going to have a presentation from Anna Cooper on key workers and a little opportunity for questions and answers. And then we're also going to have a work plan update with the plan that we put in place over the last month or so, I guess it's been. And that, I think that's it. If anyone has anything to add to the agenda, please let us know. Otherwise, we'll let Anna start with her presentation.
I'll take it away. So it's a small group today. This may be fairly quick. We'll see how we go. So if you could just go through to the next and then the next. What I'm going to speak a bit about today is one of the recommendations that's been put forth by this group and larger participants that came together back in September. And it's one of the recommendations that would be included in the, it's one of the recommendations that we're working on. So what I'm going to tell you a little bit about is some of the literature that we found, and one or two documents in particular that we identified. And I'm also going to outline a model that I worked on. I will agree that this is a few years back. Kristen, you'll probably remember this model. You may actually be able to give some updates on it, but it's a good illustration of an example of what a key worker model could look like. So that's pretty much what I'm going to talk to you about. The way it stands right now, the recommendation that we've got written is what you see on the screen in front of you. I'm presuming everybody can see the screen that's on the call. So it's just, you know, key worker is identified to facilitate service planning and care delivery in collaboration with a family or caregiver with the goal to empower the family. So next slide, please. So what we found in the literature, and really I'd like to call out to the two people that helped me with this, it's Kathy Badeau and Marie-Joëlle Doré Bergeron. And I don't know, I know Kathy wasn't going to be able to make the call. I think Marie-Joëlle was going to, but perhaps she's a bit late. But what we found was that there was really a lot of examples of key worker and the key worker model, although it was really manifested in different ways depending on the organization. So sometimes it was a designated individual that was identified as a key worker. There was also sometimes, and certainly in many larger facilities, there's a complex care team, which in many respects has a lot of the elements of a key worker and the key worker model. So we've included that in there as well. Some focus more on the clinical sides of the needs of the child and the family, and some focus more on the community needs. You'll see later on the one that I'm going to talk about that we were involved with really addressed both of those, and I think we'll also probably put forward the thought that it really does need to address both clinical and the community requirements of the child and the family. So next slide, please. So one of the articles that we particularly liked was one written by a group called the Chartist Group, and it was a white paper that outlined several care models for children with medical complexity. And we can certainly provide the references for this. What I'll do is I'll send them out to you, Lisa, later on. And the article talked about several key elements that the key worker, individual or team, really must support. And this was their findings. So I'll go over these 7 key elements. So next slide. So the first one was really that it has to focus on the child and the family's goals and needs. And I think that probably seems pretty self-evident for everybody on this group, but you know, it really has to focus on the individual child and the family. It's not something that the organization should be the focus of. It really is the needs of the child and family, and that's actually a tough concept for some groups to really embody. And it has to really extend beyond just the clinical outcomes. It really has to align around the goals of the family and the goals of the child, whatever those may be. And they're really going to be different from one child and family to the next. So that really has to be the focus of the model. Next slide. There has to be the development of a comprehensive child and family-focused care plan within that model. And it really should be up to the children and the families to identify those goals and the outcomes. Every family and the children within those families is going to have a very different set of outcomes and goals. And sometimes it's difficult for them to actually articulate, but that really is that's really an integral part of the care plan that needs to be developed. And again, it needs to really include those activities beyond just the clinical circle, because these children and their families are there for usually quite a long period of time. So those goals and outcomes are often beyond just those clinical goals, and that's what's really important to those families. Next slide. So it really, you know, I keep saying this, but it really has to include all areas where the child receives care, and so this really can include acute care, home care, school, community, and the model really needs to facilitate engagement, coordination, and communication amongst all of those providers in all of those settings. Because that is really where that child lives their life. And again, these children are on services usually for a long period of time and transition between those different areas of care. Next slide. So that key worker, again, whether it's an individual or a couple of individuals or a team, again, that key worker has to support all of those areas of the child's life. So it's, you know, I think this is why we would probably suggest that the key worker is not just one person that is, you know, that is solely responsible for their clinical outcomes, because they really need to be involved and integrated with those areas of the child's life that are outside of the clinical care and the health system. So really, you know, just what it's saying here, they need to promote, they need to maximize independence of the child. They need to optimize the social interactions of the child and the family, and they really need to look at that transitioning, not just to adulthood, but amongst the different areas where they're receiving care. Next slide. The model also needs to define how they're actually going to support the child and support that care delivery, because it's, you know, it's easy to say that they need to do this, but they need to specify what are going to be those communication processes. When is it that key worker is going to be involved? To what degree? When is it important? What are the sort of the milestones, perhaps, in the child's life that require that touch point of the key worker? You know, is it when they're changing from acute care to rehab? Is it when they're moving from primary school to secondary school? All of those things need to be identified up front. They need to be agreed upon, and then that's what becomes the model of care for that particular child and their family. Next slide. And as I said, it really needs to include that integration with the services. So, you know, that's also the financial support, their community activities, their equipment. And again, you know, the focus needs to be on achieving that optimal achievement of the child's development and the child's independence, whatever that level and goal may be for that particular child. And they really do vary quite markedly from one child to the next. Next. And lastly, it absolutely has to include plans for transition to adulthood. You know, that transition may start as the child comes on service, you know, even though the child may be very young. Eventually, you know, hopefully these children will be transitioning to adult care, and in some cases that can take many years for that transition to occur. So, and again, you know, focusing on not just transition to adult care, but really that achievement of adult independence in whatever level that child is able to achieve. So next slide. So the article also spoke to the keys to success of that model, and there were the sort of 5 keys to success that that they outlined. There really has to be leadership alignment around the goals of the program, and I'm not talking necessarily about the goals of individual children, but really the goals of the program of the key worker program and the complex care program, I guess, if you will. There has to be agreement amongst all the groups on specific measurable performance requirements to support the value of that program. Not just through the providers of care, but also the payers or the funders of the care. There has to be that agreement up front of how it's going to be measured and what those measurements are going to be. And again, there has to be active engagement of the funders because in many cases, if the funders aren't on board, the programs probably aren't going to move ahead successfully. There has to be adequate support for that key worker team, and that, again, is not just financial necessarily. Sometimes it has to be time support. It has to be, professional experience support. And there has to be that allocation of all of that support into the model in order for that model to be successful. Next slide, please. So I'm going to tell you a little bit about a model that I was involved in, and I agree this is about 5 years ago. This is when I was at the Community Care Access Centre in Toronto. But it really highlights what a key worker model could look like. It's one example of a key worker model. As I said, there's many iterations of what it could look like. But this was a model that was developed in partnership with 3 organizations. So the Acute Care Hospital, and that was Sick Kids in Toronto. The Home Care Service Coordination Organization, and that was the Toronto Central Community Care Access Centre, and the Community Rehab Hospital, and that was Holland Blue Review Kids Rehab. So it was really based on a triad model where there were 2 key workers. There was a clinical key worker and a system key worker. And then the family was the 3rd member of the triad. Next slide. So this was the conceptual model that we put together. So if you see in the middle, in the very middle is the child. Over top of that is the family, and they do, pretty well go together hand in hand. Not always, but, almost always there is some type of a family surrounding that child. And then to support that child and that family was a clinical key worker and the system key worker. And on the next slide, I'll tell you a little bit about what those 2 different key workers covered. So next slide. So the clinical key worker, their primary focus was the clinical needs of the child. So typically they were a pediatric nurse. Some of them were nurse practitioners. They were certainly people with advanced skills and education and knew this population very, very well. And they really served as that guide through the clinical care of the child. They were responsible for performing the telephone triage, helping the family make those clinical decisions or making them if the case was such, coordinating health care, assisting the families in planning for the key transitions that were related to the clinical needs of the child. They were there really to ensure that interface between the child and the family and all the providers and key services and organizations. But if you see on the next slide, they worked also, though, in conjunction with a system key worker. In this particular situation, the system key worker was a CCAC care coordinator. And they typically provide case management, but their focus was really on the community resources and coordinating all those community resources for the child and for the family. So their sort of area of expertise was very multi-functional. It was very cross-sectoral across many services. They worked to make referrals. They secured relevant resources for the children and for the family and really helped the family plan and navigate the larger community system. And then together with that clinical key worker, worked to provide that collaborative support between the 2 different areas that the child typically was at. I should note too, there are clinical care, or there are rather care coordinators located in the acute care facilities and in the rehab facilities. Certainly at the Toronto Central CCAC. So following that model, there was a study that was done that really looked on the findings of that integrated complex care model that was put together there. And what they identified was a number of enablers and barriers to this type of model. Most of them you're probably not going to find very surprising, but the enablers of the success of the model at the system level was certainly the dedication of organizational stakeholders to work together. So that meant really everybody that was there from that leadership position coming together and saying, yes, this is what we are all together going to work on, and sticking with that plan. Also the timing, so that, finding a time that aligns with regional priorities. So whenever you can align with, say, provincial priorities, you're going to have a much easier time, of course, and that is certainly what they found with this model. Certainly strong project management. So, a project management team that has an in-depth understanding of the population, of building that team, of coordinating the project. Of course, whenever that's possible, that's going to help the project success. And then strong leadership amongst the people that were with that project. Certainly at the family level, what the families identified as enablers was good communication. And I mean, it goes all the way down. So it's communication between the families and the key workers, communication between the key workers, and between the key workers and the health providers. So health providers, I would mean whether it's acute care health providers at the hospitals or the rehab facilities, or health providers in the community. So conversely to that, of course, there were some barriers to the model's success. At the system level, assumptions of what the other partner organizations could do, would do, were doing. That certainly came up as a barrier to success. Differing organizational structures, that's a big issue. Acute care facilities are very different from community care facilities, amongst home care facilities from one company to the next. There are different organizational structures and mandates and priorities. That was certainly an issue that came up. Communication was an issue, between the members of the model, and of course between the organizations. That was a big issue. And then limited engagement from the different stakeholders. What the system respondents noted, though, was most notably amongst the primary care connections. And I've got to say, actually, from my recollection of that model, there was not much engagement of primary care. So, quite likely the model didn't include primary care from the get-go, which could have resulted in the fact that they were not that engaged throughout the model. What the family noted, though, for barriers to success was really, constrained resources. So, pre-existing caseloads that the case managers had, that the nurses had in the hospitals. That was certainly noted as a problem. Governance was a big issue, and I think we probably all faced that. Every organization has different governance structures, has different priorities within that governance structure. That was certainly an issue that was identified. Policy barriers, specifically, they noted policy barriers related to information sharing, and I think we all still struggle with that. Can we send emails? Can we send texts? Do we have to do it by written communication? Do we have to be engaging people verbally? I think that still continues to be a challenge. Branding of the model actually came up as an issue that the families identified. So, there was concern. Who was in the model? Who was not in the model? What did the model mean? What did it not mean? What did it include? What did it not include? So I think there could have been better, marketing of the model at the beginning to help families better understand what it was all about. And interestingly, families noted the limited engagement in this case more from the education sector. Again, I would say, though, that we probably didn't engage the education sector that much at the beginning. So again, perhaps it's not that surprising that they weren't that engaged. So next slide, really just in conclusion, certainly what we're finding now, that there's many, many iterations of what a key worker or a key worker model could look like. I would probably suggest that it depends on the organization and the population that people are working with. However, regardless of the different iterations of it, there's still common key elements or common principles that we could probably adhere to. There are still, though, larger health system constraints. And there's all sorts of constraints that are still out there. I think part of the constraints that would exist, though, relate to the lack of understanding by the the population outside of this group about the complexity of the lives of children with medical complexities. Maybe somewhat specifically related to the long-term needs of the child. I think a lot of people don't necessarily understand where these children fit and the fact that their needs cover everything within their life and everything really within the span of their life and the life of their family. And again, that lack of understanding of the needs of the family and the economic impact on the needs and what, if those needs are not being met, the economic impact on society. I think there's a lot of people that really are not aware of that, and so they don't take that necessarily into account when some of these models are being developed and enacted. So that pretty well sums up what we came up with. I think the next slide just opens it up to some questions from the group. So I guess one question I would have to you, Kristen, do you have anything to add? I don't know how well you remember that ICCM model. I just wondered if you wanted to add anything specifically about it.
No, I wasn't that involved, Anna, actually, because that was just shortly after I had joined, actually, this organization. So it was pretty new to me, yeah.
Okay. No, I just thought you might have something to add, but no, I certainly understand that. So any questions from anybody?
Anna, it's Natalie. A great presentation. I have to say, having worked with the similar project here in our region, all of that you've listed about the the benefits and the challenges and the barriers, I would agree with everything that you have delineated and highlighted.
Mm-hmm.
I guess,
and unfortunately, they haven't changed much, I don't think.
No, I guess I was. I will ask you a question that was put forward to me because I've been working in trying to develop a clinic on the adult side, similar to what we're providing on the pediatric side, and one of the executive told me, said, wow, you do show evidence that you're changing the healthcare utilization. You do show some family satisfaction. There are definitely some improvement in being able to reach out and integrate somewhat the care. And his question was, if I had the opportunity to start and replicate this on the adult side, what is it that I would consider doing differently to continue to make this better? And I have to be honest, I'm not sure how to answer this. So I don't know if you would have.
And I'm not sure I know how to answer it off the cuff, but so when you say, or when he's asking how you would do this differently, what do you mean by differently? Differently from what?
So what he asked me, he says, obviously there are things that you're doing are working well. So what are the ingredients that you would maintain? But what is it that you would add to improve and overcome some of the barriers that are being
Right. And I'm not sure I have an answer either. I guess I'd look probably at the things that families are commenting on that they're needing more of, and maybe those would be the things to change. Are there things that, I don't know, I mean, related to specific outcomes that, are there things that aren't being met? I think so, and again, I'm just saying this off the cuff, that there's probably challenges that would be very difficult to change because they're probably outside of your power to change. Yeah. And those might be the things that you would identify that would need to be changed the most. I don't know. I don't know how to answer that. I'd have to think about it a little bit, I think, Natalie.
Okay. Thank you.
Any other questions or comments?
This is Lisa. So we were at the CCKO meeting last week, and they talked a lot about their satellite clinics, and I don't know that they called them key workers, but they are key workers in my opinion. We're all be nurse practitioners. So in your research, and you're looking at the research, was there sort of a specific type of person that should be a key worker in the clinical side? Would it, would it have to be an NP? Like,
I don't think so necessarily. I think it needs to be somebody who's got, certainly an advanced level of education and understanding, but I think it's somebody who really has that strong knowledge of that population and an understanding of not just the child but the family and the needs of those groups. So I think it's really somebody who has that holistic understanding, and then of course the education to support that. I think sometimes the advantage, I know the model that we had, we did use nurse practitioners at Sick Kids as the clinical key worker. I believe, though, that the reason we did that is we were looking more for them to take a bit of a role, certainly as a consultant, to sort of support that primary care role. I'm not sure, I think what we were really looking for is that overlap between the two workers, so that, for example, if a child was in the hospital, there would be that integration of the community key or the clinical, the system key worker, the community expert, to be involved and up to speed with what's happening in the hospital, and vice versa, so that clinical key worker to really have a strong understanding of what was happening with that child in the community, to the point where they were actually going out and making home visits to see how the children were doing in the community, so that there was much better integration between those two areas of care for the children. So I don't know necessarily that needs to be a nurse practitioner, but it does need to be somebody who's very comfortable with that population and the needs of the population.
Okay, great, thank you.
And how many children did you guys look after in that model?
Oh, no, that's a tough question. It was quite a few, because I remember sitting down with A.L. Cohen and going through all of our children that were receiving services, which was quite a few, and identifying who was appropriate. It was, I can't remember, Natalie. It was I would say over 100.
Because one of the big questions I have, at the symposium and for quite a number of years now through the CCKO, we've identified the number of children that would meet the definition of children with medical complexity that are technology dependent, because that seems to be the group that really high user of both the hospital and the community services in all layers. And when I look at the models that are evolving, it's very limiting when you look at what they're providing in relation to how many children they can provide that care to. And so, for example, the average number is that I've seen quoted, even in the literature, is around 60 to 80 children per key worker. So if we're looking in pediatric that we have, over 6,000 children in Ontario, is this realistic?
Well, I think the model that we were looking at was utilizing people that were already caring for these children. It was just identifying a specific role that they were responsible for. So care coordination was still being provided and had always been provided by CCAC care coordinators. So that wasn't a new person being brought on. Arguably, there might have been issues related to, how many of those that they could actually manage. And then again, we were using the nurse practitioners that were involved with these children already at Sick Kids. So it's not like we were bringing on new people, but we were just sort of articulating the specific requirements of those roles for this particular population group. I think it depends too on how much they become involved with these children and the needs specifically of those children at that particular time. Not all of these children, though, required intensive intervention or intensive involvement by the key workers at all times. So I think it depends on who's already looking after these children and whether they can embed it into that. And then, of course, it, you know, as you know, these children, as I just said, don't always require intensive care.
Yes, they do.
You know,
they change from time to time.
They really do. They really do. They need to have the flexibility. The people in these roles need to have the flexibility and the time to be able to take on the needs as they change. But you know, so I would suggest that you know, if you had a caseload per se for a care coordinator, it would probably be a bit lower than it might be for children that aren't as complex. But it didn't change the way we were doing it. It didn't change dramatically. We already had a population-based model, though, for case management, for care coordination at CCAC. So we already had 4 care coordinators whose caseloads were made up entirely of the more complex children, and those were the system key workers. But we didn't bring anybody new onto the program as far as key workers.
And did your key worker that were in the CCAC organization, did they express that what they were doing in terms of care coordination, did it change what they were actually doing from before?
I think it changed a little bit. I think it became more refined, but as I said, they were already dealing with this group of children. They already had caseloads. I'm trying to remember what their caseloads were like. I believe they had about 100 children on their caseloads. Again, not by any stretch were all of them, you know, of really high complexity, but, you know, many of them were. But they were already working with those children. So it was just, again, as the needs changed, you know, for some children, they might become more involved with one particular child and their family, depending on the needs at that particular moment. So, but they were the people that were already working with the children in, you know, in the community with regards to the education system. So they already knew about that. Some struggled with it, some did not. It really also came down to the individual care coordinator.
Hi, it's Kim Hogan. I just wanted to comment. So we have a sort of similar model at Sick Kids where we have multiple satellite complex care clinics throughout the communities and that service complex care patients in their home communities. And we have approximately 75 patients per nurse practitioner for like a full-time equivalent. And yeah, the caseload of 75 is reasonable. Not all of those children, as just discussed, are like have, you know, really high intense needs. It's very fluid. It changes all the time. It really depends on the time of year. During cold and flu season, the patient's acuities will change a lot. We'll have lots of emergency room visits, lots of clinic visits, lots of admissions to ICU. But 75 is our caseload for a full-time nurse practitioner.
Yep.
I just have Lisa again. I just have a sort of another question around sort of the relationship between the 2 key workers and that communication. Was it like maybe you probably said this, but I've just missed it. Did they have sort of regular meetings or check-ins, or is it just all sort of email? They did have regular meetings, and we had regular project meetings too, where we would review, you know, the children and issues that were coming up. But they had a bit of that relationship going into this model with these nurse practitioners, because these were the people who were often following the children when they were in hospital. So so yes, they did have regular meetings, and I would strongly suggest that be part of the model. And that sort of role clarity, that these are the things that I need to deal with, and these are the things that you need to deal with, and we don't need, you know.
Exactly, and exactly, and I think that was on one of the slides. Is really, you know, that needs to be established up front. You know, where do I step in? Where do you step in? Where do we step in together? When do we communicate? What are our touch points? Yeah. And then, of course, that needs to also really revolve around what the family's goals and needs are going to be too.
So this is all really closely linked with that care plan as well. So it's, yeah.
Yes, absolutely. Anyone else? There you go.
Oh, thank you very much.
Yeah, that was great, Anna.
Great, thank you. Lisa, do you want to move into updates? The last 15 minutes?
Yeah, so all I can say to that is that we've, each of the groups, I think all of the groups have sort of touched base and started on some work. You can see that Anna's group, I think they met just before the Christmas break, so maybe they had a bit of a head start. So they're moving quite forward with their literature and evidence review. Kristen, a couple of the groups have been lucky enough that they have research assistants that can help with that sort of evidence search, and so they're sort of moving ahead on that. I don't have any reports from any of the groups per se. I don't know, Kim and Karen, we're just sort of getting going with collecting our evidence right now. So I don't know if anybody has any other real updates. We were hoping that maybe we would be able to have a first draft of an evidence summary at the end of March in each of these groups. We may, but we'll aim for that and hope for the best. So it's always a tricky thing. So I don't know if any of the people on the work groups have found any other information or have had some success or things that they want to share. I don't know, Anna, if you want to talk about a bit of your process and what you did. That might be
for identifying what we came up with.
Yeah, sort of how you worked with the three of you worked together and.
I got to give a lot of credit to. Sorry, I just had a nice bowl of soup brought to me. So Kathy and Marie-Joelle and I worked together, and I got to give a lot of credit to the two of them. They were able to access some of the literature, so we really, we identified what we wanted to find out about. Some of it went back to the questions that I think you had put into that, the recommendations framework. What were the sort of general parameters that we wanted to come up with to sort of flesh out that recommendation. We came up with about 10 or 12 articles, and then from then had some discussion about what was in them and what some of the similarities were. As I said, I referred to that one document because it really encapsulated what was in many of the articles. So from there, we just identified some key principles that seemed to be fairly predominant. And then I just gave you that example to show what it might look like. So it was pretty straightforward what we did. We did not have a research assistant. We had access to literature. The other two had access. I don't have great access. So that's pretty straightforward what we did.
That's great. That's helpful so that people know that they don't have to move the sun and the earth.
Not at all. Not at all. And I mean, I think we need to look at the literature. We need to see what's there, but I don't think we're looking for exhaustive literature reviews for any of these things. I don't think we can. I don't think we've got the time or the resources to do that. So I was just gonna make one other comment, Lisa. I think the other issue, because we're going to be making these recommendations for a vast array of organizations and groups of people, the recommendations need to be fairly high level.
Yes.
Otherwise, people aren't going to understand how they could use them. I mean, I guess when they are that high level, people don't necessarily understand how they can use them. But if we're terribly prescriptive and specific, there's going to be a lot of people who are going to look and say, well, it doesn't apply to me at all, and that's going to be the end of it. So I think we did try and keep that in mind too.
That's a really good point. And also, I think that we can, like you just described a model how this can work, how this has worked. So when we have those examples of how things can work in different settings, I think that's really helpful for people. There's something already existing that you can look at to say, okay, well maybe we could do this slightly different for our population. But
now I will point out, I'm not sure that model is anywhere near up and running. I believe it moved on, it shifted, it changed. Again, Kristen, you may be able to speak more to what's actually underway at CCAC, but I would also say that there are models similar to that springing up all over the place.
Yeah. So I don't know, Natalie, I know that your group hasn't, well, I don't know that you have a group actually.
Yes, so Lisa, that's really me and question of time. So I know that Emma has been very interested in this. It's just we haven't been able to connect and move this forward. And I know you had connected me with Carla as well. So it's a matter for me to continue to move this forward.
Okay, that's good. And I know, and like again, I do understand everybody's sort of restrictions with time, so we do the best we can with what we with the time we have. So I really appreciate all of that. I don't know, Kim and Karen, we're just chugging.
Yeah, we're just getting started, right?
Yeah.
We've got some files. This is a good start.
Yes.
So yeah, we've got some articles. We're on our way.
I don't know if any of the other groups are online. So that's pretty much it. We have had I think some parents that wanted to, or are being approached to be part of this whole process as well. So I'm not sure who all has come aboard yet, but and again, I was speaking to Darren at in Toronto last weekend, and last week rather, and he's willing to sort of participate on one of the groups as needed. I'll make sure I connect him up. So I don't know, Karen, Kristen, or Natalie, if you have any other add.
No, I have nothing further to add, Lisa, on the updates, if that's what you're referring to at this time. No. Just great that, as you know, everyone's busy, so it's just great that, we're continuing to move forward, and that's good to hear.
Yeah, keep our momentum.
Yeah.
And again, we have succession planning on the agenda. As always, we are looking, Natalie and Kristen are looking to retire their titles, and if we would really appreciate if someone could sort of come on board and help with that co-chair piece, and to keep the momentum of the group. So we really do need folks to help out with that. So I'll just keep putting the plea out and hope for the best. I don't know if anybody has any other sort of updates or exciting things that have happened in their programs or at their organizations, or next month, Allison Chu from CCMCH is going to give us a bit of an overview and debrief of the day that they had last week with the CCKO symposium that some of us were able to attend. So she's going to give us some highlights of that day and some of the thoughts that came out of it. They had a bit of a World Cafe, many presentations, and then a sort of a World Cafe where different aspects of care planning and things were discussed. So there should be some good information that comes out of that meeting. And it really aligns with the things that we're working on.
Yeah, I agree. That was a great day.
There was a lot of discussion about key workers, care plans, and transition. So I think some of the major things that we'll be looking at. So I don't know, ladies, if there's nobody has anything else, we can probably just adjourn.
Yeah, no, I don't have anything else for the agenda today. Again, I think we just have those work groups in progress, and that's really the focus right now. Natalie, I don't know if you have anything that you wanted to add.
No, I think this was a great presentation today, really focusing us on the different agenda issues for those recommendations. So great work, Anna. I think this is excellent, and if we can all continue to move forward in that direction, that'd be great.
And just a note, Lisa's got the presentation if anybody wants to refer to it.
Yeah, it'd be nice to have access to it.
I'll do that, and as I said, I'll also send Lisa, I'll send you I think we narrowed it down to about 8 or 9 articles, and I'll send you all of those as well.
Perfect. Thank you.
Okay. All right. Well, if there's nothing further from anyone, I think we can adjourn.
All right.
All right.
Thank you.
Thanks,
Thank
Anna.
you.
And thanks, everyone.
Thanks, everyone.
Okay, bye-bye now.
Bye.
Bye.